Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy with my colleague Alan Francis. Good morning, Alan.
Hey, Marvin, how are you?
And I'm Marvin Goldfried. And so today we're going to be talking about the topic which seems pretty obvious as far as an answer is concerned. Namely, don't blame the patient. And it seems pretty obvious that that's not what therapists should do. But then the question is, why do we even need to raise the topic if it's so obvious that it's not a good thing? And that's because some therapists blame the patient.
I remember a very vivid moment when I was at Cornell. This is going back, about 40 years ago. And we were at a meeting with the residents, the staff. Must have been about 150 people in the room. And one of the residents got up. I was head of the outpatient department. And he got up and had the nerve to say, and I want to bring up the point that Dr. Francis is sending us shitty patients. The patients that they were getting referred for psychotherapy were shitty patients. And I got up and said, Dr. X, I've known a lot of shitty doctors. I've known very few shitty patients. The tendency for people when they're frustrated with lack of progress, for therapists, when they're frustrated with lack of progress in the therapy, it's a natural human tendency that even many therapists have to blame the patient for the lack of progress rather than to look at problems in the relationship or problems in the techniques being used.
Or the problems in the lack of knowledge of how to deal with certain kinds of patients.
Exactly.
So we talk about the patient not being ready to change, or the treatment-resistant patient. I don't know how you feel about that, but
yeah, well, the term treatment resistance is an unfortunate one. I really hate the term, and part of the problem started with the early psychoanalysts, that they were treating symptoms, not character problems in the beginning. And when the patients didn't cooperate with the analysis of the symptoms, this was called resistance. It was attributed to the patient's unconscious tendencies not to want to reveal the source of the problems. But it put the onus on the patient. It was as if the patient was resisting, not that the therapy was not doing what the patient needed.
Yeah. And then you take that one step further, and it's like you don't want to get well. So it's not just describing them as resisting, but it's also attributing a motive to it.
Yeah, and this got the fancy name secondary gain, as if there were a conscious or unconscious manipulation to use the sickness as a way of controlling the environment. Sometimes this is true, but it's too easy an explanation to take the therapist off the hook, the therapeutic relationship off the hook, and the techniques off the hook.
Yeah. So, do we come to the conclusion that there's something about psychodynamic therapy that can easily lead the therapist into blaming the patient because of theory?
In my experience, it's true across all therapies that this is a problem, but I think it can be especially true in psychodynamic treatments. And the corollary to that is that people doing psychodynamic treatments have to be on their guard, not to have the self-assurance that if something's going wrong in the treatment, it's due to the patient. I think one of the nice things about cognitive behavior therapy was it introduced the idea of checking with the patient. How are we doing?
Yeah. What just came to mind was when I had a therapist who was very psychoanalytic, who sat behind me. I wasn't lying down. I was sitting, but he sat behind me. And during one session, he fell asleep. And I called him on that. And he said, well, if you said something that was interesting, I'd stay awake. That may have been the last or next to last session we had.
Good for you.
Yeah, I mean, it's we do know that when the therapist blames the patient, even if it's subtle, and that was certainly not so subtle, that there's a negative impact it makes on the patient. They get worse. So it's not just that it impedes treatment, it could also cause harm.
Yeah, and I think another of the concepts that can be misused, again, each of these concepts is very valuable if properly used, but if misused is dangerous. Transference is a very valuable concept. The idea that people bring into each new relationship whatever conflicts and problems they've had in past relationships, wonderful concept. But the trouble is it's too easy for therapists to hide behind it and assume that anytime the patient is upset with the treatment or upset with the therapist, it has to do with a reenactment of some past being upset with someone else, rather than it being a perfectly appropriate anger or upset due to the fact that the therapist has said or done something that's hurtful or painful.
So do you think this is attributable to the theory, psychodynamic theory?
I think it's a misuse of the theory.
The misuse of the theory, okay. Yeah, so there's a notion that something is a derivative, which means what you see is not quite really what is there, that there's something else that's there. So you don't take things at face value, because there's something deeper that is motivating.
I've known very famous psychoanalytically oriented therapists and teachers, world famous people, who do interviews with patients that are outrageously infuriating. That on the face of it, as you're watching the interview and you put yourself in the patient's position, you'd be saying to yourself, I hate this guy for saying that. But the interpretation afterwards is, aha, this was a transference to me. The patient got angry at me because of X, Y, and Z problems they've had in their past with other important figures in their lives. A kind of avoidance of any responsibility that the real life experience in the room could, for some patients, it sometimes be infuriating and may have been a mistake on the part of the therapist. Transference allows you to hide your mistakes behind the cloak that it's a patient's previous experiences rather than your current behavior that's causing them to be angry at you.
That's an interesting point. I remember once being on a panel at a meeting, and I asked the question of my psychodynamic colleague on the panel, how do you know when you have a negative transference versus a rupture in the therapy alliance? And the response that she gave was theoretical. Well, one is something to do with what's going on in the here and now, and the other has to do with a more important telling of displacement of reaction. I said, yeah, I know the theoretical difference, but how do you tell in a session whether it's one or the other? And there was no good answer, at least no answer that satisfied me.
I think my answer to that question would have been something like, I'd find out what they're angry about. What did I say that bothered you? What was the tone of voice? What was the other behaviors that have annoyed you? And rather than jumping to, aha, this proves that you're angry at your father, tell me more about what I did and take seriously the possibility that this is not a transverse response, but rather a realistic response to something stupid I said.
So making, and that's certainly, being very, very careful in the wording. And I think that if it is, let's say, a legitimate transference reaction, it's important, I believe, and what do I know? I'm not psychodynamic, really.
Yes, you are, Marvin.
But
You are psychodynamic.
well, I don't pay dues, so I'm not.
You don't pay dues, but you speak Freudian prose without being aware of it.
Well, maybe it's unconscious. I don't know. It's even just making any kind of interpretation. How you say it and the context in which you say it can be very important, or can be an accusation, a blaming.
And very often the therapist isn't aware of the fact that the tone of voice, the facial expression could be interpreted accurately or maybe slightly misinterpreted, but still related to what you've said and done, not necessarily
Exactly.
the response to the past.
And exactly. And with certain patients, they know you're annoyed before you know it, because they see it in your body language, voice quality, facial expression.
And not just annoyed, it could be bored.
Yeah.
They can, the little yawn you're suppressing.
Yes. Right. So the research that's been done on blaming the patient and quote hostility toward the patient hasn't been overt, real blatant stuff. It's been subtle stuff. And certain patients who've grown up with that have incredible radar. So they can see it beforehand. And I think a wonderful example is the borderline personality who grew up with criticism. And one of the biggest contributions, I think, of Marshall Linehan was not solely toward how to deal with borderlines, but how to do good therapy. The recognition that you've got to be real careful. You can call it countertransference. You can call it anything else that you want, bias. You can call it frustration because the patient is not changing. You can dislike the patient because they don't share the same value system or don't have the same background, or you're having difficulty understanding them and you blame them. There can be lots of roots to that. And it doesn't have to be a borderline patient.
Like the sign on the way to the ancient Greek healing hospitals was often know thyself. Major part of healing was to know thyself. And I think for therapists, it's a crucial part of being a useful helper rather than a adversary in therapeutic relationships, to know yourself, to know your susceptibilities, the cues that set you off in different directions.
Yeah.
And part of why I think that it's important for therapists to have their own therapy as a way of increasing their insight, to reduce their tendency to blame the patients for problems, to be more introspective and more ready to accept patients' views of them that would otherwise be ignored or denigrated as transference, because they begin to understand that what the patient's seeing may not always be a transference distortion, may actually be an accurate representation that previously they were unaware of what they're really like.
Well, wasn't that the original rationale, to have analysts analyzed personally so that they could know that themselves?
And I think it goes well beyond, psychodynamic therapists, that anyone who's going to be a therapist should spend some time trying to understand themselves better. And since most people have blind spots to the things they most need to learn, that will probably entail being in their own therapy.
Yeah, and I think, and as you say, it goes beyond just being psychodynamic. I would venture to guess, and I don't know if any research has been done on this, but I would venture to guess that some CBT therapists or some therapists who are trying to intervene with a CBT orientation and have the opinion that the relationship is far less important than the technique may be more likely to inadvertently blame the patient, because they're not being sensitive and may not have been supervised to pay attention. So the CBT therapist could be frustrated or disappointed if the patient doesn't do some self-recording homework. Oh, why didn't you do your homework? So that tone of voice is accusatory, and they may not even be aware of it.
Yeah, I've never known a patient to perfectly do the homework. Yeah, I think that for the most part, patients will find ways of doing parts of the homework, or they'll do other exercises that are serving the same purpose, but their way. And for CBT therapists to have the perfectionistic expectation that patients will do the homework because it's been assigned misses the point of the assignment, which is often more metaphoric than the expectation that it'll be done by rote.
My thought for a long time has been, if you believe that all behavior is determined either by past psychological factors, current psychological factors, biological, constitutional factors, then the patient is never wrong. They are obeying all the laws of human behavior, psychologically, physiologically, etc. They are very good citizens. So if you say that the patient is never wrong, then it's up to us as therapists to understand why something is happening rather than sanction it.
I love that. And I think that a corollary to that is that many therapists are way too perfectionistic about and too ambitious about their expectations of what therapy can achieve and how fast it can achieve it. That people change at their own rate or change not at all. And the expectation that a patient isn't changing according to your sort of pre-established mental image of how fast they should change, how far they should change, is a recipe for disappointment in the treatment and yourself, and then very often projected onto the patient. Why aren't they changing faster? A lot of people aren't going to change. They're just coming to therapy for support, for advice. They're not going to be very different at the end of it, but they may have needed it as a way of getting through difficult portions of their life because of job stress, family stress, health problems. And we should try to have the same goals, or maybe slightly more ambitious goals, but not much more ambitious goals than our patients. If we expect too much of them, we get disappointed and angry.
Yeah. No, I'm listening to what you're saying, and I'm thinking clinically, and then I'm also thinking empirically. And clinically, I say, yeah, of course. Some people have had such severe problems, and they occurred so early in life, and it's confounded and compounded by constitutional deficiencies, that there's only limited change that's possible. But we know this clinically. And then I'm thinking from a research point of view, well, what's the evidence for that? I'm not quite sure. I mean, there may be some evidence, but I'm not quite sure there's nearly as much research evidence as there is clinical observation for that, because of the nature of the research that's done, where we look for main effects rather than interactions.
Hard to study, but one thing that's interesting in this regard is how well the control group supportive therapies that are meant not to be specific techniques, compared to specific techniques, how well they do.
Yeah.
And it goes back to Rosenzweig and the relationship and so forth. But I think it also suggests that for many people, the expectation that we will apply a specific technique and this will have a specific result is overly ambitious, and that the patience and willingness to go at the patient's pace rather than our own ambitions reduces the disappointment in therapy, reduces the disappointment in the patient, in ourselves, reduces the anger. This patient is not performing. Yeah. This patient's resistant.
Right, and I think it's important for the therapist, not only the therapist to be aware of this, but to convey this to the patient. I've been working with one patient on a certain issue for a while, and I think we've gone as far as we can go. I mean, in the course of therapy, and it's something that he can continue to do on his own after we terminate, but the issue has not 100% disappeared. And I made a comment to him just in this last session. There are really no cures. This is a physician who's my patient. I said, there are really no cures in the same way that in medicine there are cures. We lessen things, we soften them, we make them less problematic, but under certain circumstances, they never go away. And that had a very important impact on him.
By the way, that's also true of most of medicine.
Is it?
There aren't that many cures in medicine either. That's mostly we ameliorate rather than separate the patient from the disease. So,
well, but if you have
it's an idealized view of medicine to think that, medicine cures and psychotherapy or psychiatry doesn't. It's really part of the human condition that there are lots of problems for which there won't be a cure. There'll be maybe the ability to ameliorate. And one thing Hippocrates pointed out, always the ability to comfort.
Well, that's interesting. Because when I think of medicine, I think of the goal being the cure. But I guess that's what gets the publicity, the cures. But there are certainly
most cures are hyped, but the actual results in most medical treatments, especially for chronic disorders, almost uniformly, most chronic disorders don't have a sudden treatment intervention that makes everything better. The physicians over the course of the last 2,500 years have helped some patients, but Hippocrates has a wonderful quote. I'm not good at remembering it, but it has something to the effect that we treat often, we cure sometimes, but we comfort always.
One area which is kind of interesting is in the instance of people who are socially anxious and who have a history of being shy or have a history of being behaviorally inhibited even within the first few months of life. So there's a constitutional factor, and they blame themselves 100% for this. And even though we do have good interventions for social anxiety, the person may never be 100% comfortable in social situations because of this biological tendency or physiological neuropsych tendency. And it's important for them to know this. So this is one of several examples where if the goal of therapy is not clearly spelled out and you're chasing windmills, then the patient will have failed and the therapist will have failed.
Jerry Kagan did wonderful experiments in the old days where he made noises with pregnant women and checked the fetal heartbeat.
Oh, really?
And it turned out that about a third of the fetuses had a very pronounced increase in fetal heart rate in terms of hearing this external sound. And that was very predictive of how anxious kids were versus exploratory as babies and young children. That the ones who had the big jump in fetal heart rate tended to be more frightened as babies and toddlers. They tended to be more socially anxious as they were growing up. It was a very strong predictor into adulthood of who was going to be more anxious and less anxious, proving a constitutional factor from the time of being a fetus. A lot of people grew out of it. So maybe 2/3 of the very socially anxious kids became adult socially anxious people. A lot of people grew out of it, but the tendency was there from the start. And if you blame the patient for that tendency, you're missing what their life experience is like, and you're adding a burden rather than
Right.
providing comfort and
Yes,
help.
because they are blaming themselves because society blames them. What's the matter with you? Just, you're standing on the outskirts in the playground. Go and play with the other kids. And the other kids make fun of them because they're loners. So that there is this tendency for the self-blame. Anytime I've worked with a socially anxious person, these were all adults, I would tell them about Kagan's research, and that nurses can tell whether baby is going to have problems or not.
You know, one of the interesting findings of that study was that the mothers who did have the kids do more rather than overly sheltering them, that those kids tended to be the ones who were less socially anxious. So it's an interaction between biology and desensitization that helped to determine the future fate.
Exactly. Yeah. Okay, my friend, this is interesting, as always.
Always is, Marvin.
And we'll talk next week.
I keep thinking we're going to run out of things to say, but so far, at least, we haven't.
So far, so good. We do occasionally get suggestions from people, and we do welcome your suggestions. We may not always are able to act on them if we just don't know anything about the area that you're interested in, but please keep those suggestions coming and stay safe. Talk to you next week, Alan.
Bye-bye.
Take care.